Hello guys, welcome to Anesthesia. Today's video will be discussing about an important instrument, that is fiberoptic bronchoscope. So it's an important instrument that is we use in difficult airways algorithms, as well also forms a part of the difficult airway cart. So it's an instrument which requires proper understanding and techniques and an experience for usage, for its proper use and optimal use. So in this video, we'll be discussing about what are the indications of using a fiber optic bronchoscope, what are the parts of the fiber optic bronchoscope. We will see about what are the various preparation we require to do a fiber optic bronchoscopy, and in time we will see about what are the views and how can, and some tips and tricks on how can we do a better fiber optic bronchoscopy and intubation as well. Right. So coming to the start of it, what are the indications of a fiber optic bronchoscope? Fiber optic bronchoscopic intubation, this is required in difficult intubations. Okay, in difficult intubations, it forms a part of the difficult airway algorithm where we can try to intubate the FOB using through a supraglottic airway device, or in patients which are having mouth opening less than or equal to 1 finger, okay, or 1 to 1.5 fingers. So where mouth opening is very less, where the blade of a laryngoscope also cannot be passed, we definitely require a fiber optic bronchoscope. And third is in case of patients with expected difficult airway, right? In cases of patients like ankylosing spondylitis, okay, ankylosing spondylitis, in patients with quinsy, patients with temporomandibular joint ankylosis, or patients who are having a huge multinodular goiter, okay, which is compressing on the trachea and is causing tracheal deviation. So these are the expected difficult airways. Or patients with post Burns contracture, okay, with fixed flex neck, we have to use a fiber optic intubation. So this is also one of the use. Where one more use where we can use it for diagnostic purposes, okay, for identifying some lesions within the airway tract we can use, or for therapeutic purposes, that is basically for the positioning of a double lumen tube or a bronchial blocker. So these are some of the uses of the FOB that we use in everyday life. So coming to what are the parts of a fiber optic bronchoscope. So when we come to the parts of a fiber optic bronchoscope, we can basically divide them. First, they'll be having what is called as an eyepiece. Okay, there is an eyepiece and also there is a focusing ring. So there is an eyepiece, okay, and there is a focusing ring. Both of them are present. Okay, then we can divide the fiber optic bronchoscope. They'll be having a source of light. Okay, if it's a video bronchoscope, they will have a source of light. Then they have the control section which is present of the fiber optic bronchoscope. Then you have the insertion rod of the fiber optic bronchoscope. Okay, this is a rough diagram I have just drawn to make you people understand, right? There is a so when we come to the control section, let me magnify it. So the control section will be having a angulation lever. So basically it is used for flexing and deflexing the distal 5 centimeter of the fiber optic bronchoscope. Okay, so distal 5 centimeter for flexing this way or deflexing, total of about 120 degree, you have the angulation lever. Then I discussed that we also have a source of light. Okay, in the front there will be a suction valve that is connected to a suction source. So this suction valve gets activated on pressing the suction. Okay, so this will be connected with the suction source. Then we also have what is called as a working port or channel. So working channel that is present is when we will be instilling the local anesthetics. So these are all the parts of the control portion of the fiber optic bronchoscope. Now we come to the insertion rod portion of the FOB. So in insertion rod, it will be containing what is called as the light bundles or light fibers that will be carried through the entirety of the insertion rod. Okay. We also have an image lens that is present, okay, that magnifies the image which is reflected from the light, and also there is the working port that is present, or the working channel that is present throughout the length of this insertion rod. So distal end of the fiber optic bronchoscope, we can see two light channels. Okay, the light channels will be basically reflecting the light throughout the entirety and ensure that the light from the light source is not like a sharp light. It's a diffuse light which will help in providing a better picture quality. Okay, we also have a lens that is present at the distal end for magnifying the image, and also sometimes we have some kind of video chip that will be connected to the control port, connected to the camera, which will help us to visualize the image. Okay, then we also have a working channel. Sometimes it's bigger in certain bronchoscopes for certain things like biopsies to be taken for instruments, or it is also present for installation of local anesthetics. Right, the distal 5 centimeter of the fiber optic bronchoscope, it can flex and deflex and provides a vision degree of about 120 degree. Okay, so the length of adult fiber optic bronchoscope is about 60 centimeter, and it is containing it ranges from 4 to 6 mm outer diameter. Okay, whereas a pediatric fiber optic bronchoscope will be about 2.5 to 3 mm outer diameter and has a length on an average about 30 to 40 centimeter. So to prepare the patient for a fiber optic bronchoscope, first we have to secure a IV line. Okay, we have to secure a intravenous access. Okay, second is we will connect the ASA standard monitors, that is ECG, blood pressure, pulse oximetry. We have to keep the drugs ready which is required for the FOB, like the sedative agents, anti-sialogogues. We have to keep the induction agents, muscle relaxants, local anesthetics, checked suctions, preferably 2 suctions may be required. We have to also keep the difficult airway cart ready, and also anesthesia machine should be checked and kept prepared. Okay, so this is the preparation we should have prior the fiber optic bronchoscope. We have to take the bronchoscope, we have to check the suction in the bronchoscope, we have to connect it to the light source, we have to focus the image on certain letters to the best focusing possible, and then we have to keep it ready prior the patient arrives. Okay, so when we prepare the patient for the for this fiber optic bronchoscopy, first is the psychological preparation. Patient has to be carefully explained regarding the procedure. His cooperation is of utmost importance while conducting the fiber optic bronchoscopy. They have to be told about the discomfort they may face. They'll also have to be reassured that the sedation and proper pain relief will be provided during the procedures. They have to be also explained regarding multiple injections of local anesthetics which they may be given prior to the procedures, and also the bad taste of the local anesthetics that may be felt by the patient. Okay, once the patient is psychologically prepared, we will see about what are the various methods or the measures which we can follow for a smooth fiber optic intubation. So as soon as the patient arrives, okay, when we are starting the preparation, first we saw the psychological preparation of the patient. Then then we see what is the pharmacological preparation which we have to do. So in pharmacological preparation, we have first is the anti-sialogogues. Anti-sialogogues, so these are basically to dry up the secretions and also will help in decreasing the dilution of the local anesthetics with the mucus or the saliva. Okay, so anti-sialogogues we most commonly use injection glycopyrrolate. Okay, 4 microgram per kg body weight. Okay, this is given like 15 to 20 minutes prior the procedures. So as I said, it helps in drying up the secretion. It will also reduce the local anesthetics getting dilated and also gives a clear vision and prevents the camera getting frequently being fogged or being affected by the secretion. So the image will not be blurry. So second pharmacological preparation is basically the sedation which we offer to the patient in order to alleviate the anxiety of the patient. Most commonly we can use like midazolam 1 to 2 milligram. Okay. Most common used is midazolam 1 to 2 milligram. Okay. We can use fentanyl at the dose of 0.5 microgram per kg body weight. Okay. Another agents like ketamine we can use at 0.2 milligram per kg body weight, or we can use induction, we can use remifentanil, which is one of the newer drugs, 0.05 microgram per kg per minute infusion, and very commonly used is the dexmedetomidine at 0.5 microgram per kg per hour. Okay, which is started about 15 to 20 minutes prior carrying out the procedure, so that the sympathetic response of the patient in response to the fiber optic bronchoscopy is attenuated to a great extent. Okay, so these are the sedative agents which can be used once, and also after this we have to also keep the drugs for the general anesthesia like our propofol. Okay, we have to keep our induction agents, we have to keep muscle relaxants and difficult airway cart ready also, as I said prior itself. Okay, so after this pharmacological preparation, how do we prepare the airway or the nasal, oral, laryngeal airway as well as the tracheal airway for the process of the fiber optic bronchoscopy? So let's start with the nasal preparation. So the nasal preparation, in nasal preparation we will be giving what is the nasal drops. Okay, we have the astringent drop, that is oxymetazoline or the xylometazoline drops that are present. We can give like 2% lignocaine and with pledgets, that is actually put throughout the nasal mucosa about 20 minutes prior to the procedure. So the nasal drops, that is oxymetazoline, xylometazoline can be used. We have to remember that the nasal mucosa with this is innervated by the first and the second branch of the fifth cranial nerve, that is the ophthalmic and the maxillary branch of the fifth cranial nerve. Okay, so nasal mucosa can also be prepared by using nebulization. Okay, nebulization with 4% lignocaine, about 5 ml. Okay, that also helps in providing good analgesia as well as good numbing effect on the nasal mucosa as well as part of the oral mucosa, right? So another way, if we are using a oral fiber optic intubation, remember to use always an oral airway, preferably like a Berman's airway or Ovesipian airway. So when we are giving a oral fiber optic bronchoscopy, we have to remember that the posterior 1/3 of the tongue or the right, then we have the tonsillar pillars. All these are innervated by the glossopharyngeal nerve. So how can we block the glossopharyngeal nerve? This can be blocked by putting lignocaine 10% sprays at the base of the tonsils at the palatoglossal arch. Okay. Another way is to place pledgets of cotton soaked with 2% lignocaine that is kept in pyriform fossa 15 to 20 minutes prior to the procedure. Some people in the olden days used to follow injection of a local anesthetic at the base of the tonsillar pillars, but it's often associated with intravascular injection because it's a very vascular area and hematoma formation. Okay, so this is how we can prepare the nasal as well as the oral mucosa prior to the procedure. Right? So coming to how do we anesthetize the posterior pharyngeal wall, that can be done by using lignocaine viscous, okay, which is in the form of 4%, that can be given as goggles for the patient, or spraying 10% lignocaine, okay, at the posterior pharyngeal wall. Okay, so this is how we can anesthetize the posterior pharyngeal wall of the patient. Okay, next we come to, as we come down further, we have finished how can we anesthetize the nose, oral cavity, we have come to the pharynx, right? Next we will come to the larynx. Okay, in larynx we see that above the vocal cords they are supplied by the superior laryngeal nerve. Okay, the sensory is by the superior laryngeal nerve, which is the above the cords. Below the cords it is by the recurrent laryngeal nerve. The sensory is by the recurrent laryngeal nerve. So above the cords, how do we anesthetize? Is by using a superior laryngeal nerve block. Okay, how do we give that block? We have to palpate the hyoid bone. Okay, the greater cornua of the hyoid is palpated. Half centimeter lateral to it, we can inject the local anesthetic in a fan shaped manner. Okay, so when we inject this, it will block the sensory branch of the superior laryngeal nerve. Remember that most of the pharyngeal muscles, which are intrinsic muscles, are supplied by recurrent laryngeal except the cricothyroid. Okay, so we can give this the superior laryngeal nerve block. Okay, how do we then below the cords, how do we anesthetize it? By using transtracheal injection. Okay, transtracheal injection of local anesthetics in a patient in extended neck position, or how much ever extension is possible, we have to identify the cricothyroid membrane. We have to identify the cricothyroid membrane. Okay, if let me show like a diagram. If this is the tracheal rings, we can just palpate. Okay, we have to identify the cricothyroid membrane just below the thyroid. Okay, the needle with the syringe, about 4 ml of local anesthetic would be enough taken. Okay, preferably Miller says that you use a angiocath. Okay, angiocath is nothing but our like a IV with a needle and a catheter over it. Okay, so you have to go 90° over the cricothyroid membrane. Once you get a give way, aspirate. You have to get air. If you get air means you are within the trachea. You can remove the needle, that is the stillet, and then just connect the syringe with this catheter of the IV line, and then you can install the local anesthetic. One thing you have to remember is while doing this, you have to tell the patient that they may cough post this injection. So it is nothing to be worried about. Okay. So we have seen the transtracheal injection of local anesthetic. One more method which is used nowadays, that is the spray as you go technique. Spray as you go technique means in this, once the fiberoptic bronchoscope reaches towards the laryngeal inlet, 2 ml of local anesthetic is given. Okay, wait for it to act for about a minute, and then you cross the cords and then 2 more ml of local anesthetic is given. So this is the spray as you go technique. Okay, so through all the steps we saw how do we anesthetize or prepare the airway, that is the nose, the oral airway, the pharyngeal, laryngeal, and finally the tracheal using the spray as you go technique also, as well as the transtracheal injections. So these preparations, the pharmacological as well as the psychological preparation is very much important for a proper fiber optic bronchoscopy and successful intubation, and also ensures a good comfort to the patient without much of sympathetic stimulation. So next we will come to how do we actually conduct the procedure of a fiber optic bronchoscope. So the fiber optic bronchoscopy or the scope is held with the non-dominant hand. So it's usually prepared to be held in the left hand of the person. Okay, it's held with the right hand that is used for maneuvering the insertion cord. Okay, if you are using a nasal intubation, it's better to first select the more potent nostril, that is the wider nostril, for doing the fiber optic bronchoscopy. Okay, so whenever we do this fiber optic bronchoscopy, I'll just basically divide the procedure into 4 steps of use which we may see. So first is from the nose to the supraglottic view. Okay, second is from the supraglottic view to the passing across the cords. Okay, third one will be cords to the carina visualization, and fourth is the railroading of the tube. Okay, so we can divide this as the 4 steps, and let me discuss one by one. So first is from the, as I said, we have to hold the fiber scope in the non-dominant hand. Okay, we have to check the lever, we have to check the suction, be prepared with the local anesthetic drugs, and also after, as I said, the preparation, that is connect the patient, connect the standard ASA monitors, give adequate sedation, proper preparation of the patient, stand at the head end of the patient, which we do usually, select the nostril which is of the wider gauge you feel. Okay, you can also gradually dilate the nostril using the nasopharyngeal airways. If you are using a oral route for the intubation, always better to use either airway, that is the ovasipian, or the Berman's airway, through which the fiber scope can pass smoothly. Okay, so post this, as we pass through the nose, we have to remember that we have to pass inferior to the inferior turbinates. Okay, inferior to inferior turbinates is how we pass through the fiber scope, that is pass through the nose. Once you reach the supraglottic view, okay, I'll put a picture. We'll be able to visualize the epiglottis, the arytenoids, aryepiglottic fold, true cords and the false cords, and the pyriform fossa. Okay, once we are able to see all this, okay, we can go on to the next step, that is from the supraglottic to the passing through the cords. Often you can tell the patient to take a deep breath, okay, while you are passing through the cords, and post that, okay, once you pass through the cords, you will be reaching into the trachea. So once you reach inside the trachea, you have to go till you will be able to see the trachealis muscle as well as the tracheal rings. You have to go till you reach just above the carina. Do not touch the carina. Ensure that you are about 2 to 3 tracheal rings above the carina. That would be your ideal position of an endotracheal tube, right? So post this reaching the carina, we have to now railroad the tube. Okay, so in railroading the tube is where we sometimes may face the problem or the issues. Okay, so in railroading the tube, the process has to be very smooth. You have to tell the patient to take a deep breath, pass the tube, and then you have to slide it down under the vision of the fiber optic bronchoscope. Okay, once you set it in place, you have to connect with the circuit, and you have to confirm the position of the ET tube using, that is, confirm that you have intubated in place using an EtCO2 graph. Once there, you can induce the patient, put him under anesthesia, that is, give an IV induction agent and a muscle relaxant with the inhalational agents and secure it in place. Okay, so often what happens that the tube that is present, that is the endotracheal tube that is present, often may get hinged up when we are trying to railroad the tube over the fiber optic bronchoscope. That is when we are trying to push it. So one maneuver which is done in case of the FOB, that is the undo maneuver. Okay, so undo maneuver means bevel up of the ET tube in nasal intubation and bevel down in case of a oral intubation. Okay, so this is a technique which can be followed. Also, if you are encountering some resistance, withdraw the ET tube and rotate it, and you can try to pass the ET tube under vision. So these are the basic steps which we have to follow while doing the procedure of a fiber optic intubation. Okay. So often what happens because of excess sedation, when we are trying to visualize, the epiglottis may fall. So you can just wake up the patient or tell them to protrude the tongue for a better visualization. Right? So what are the complications which we see? The complications usually come where there is inadequate preparation of the patient, or if it is a procedure which is done by an inexperienced endoscopist, and complications that is difficult to intubate happens in conditions where there is trauma or there is lot of bleeding. So whenever, because this is like a under vision scopy which we are doing, if the vision is very bad or if the vision is obscured because of bleeding, it becomes very difficult to do a fiber optic bronchoscope. Also, in conditions where, in conditions while using this fiber optic bronchoscope, experience matters a lot, especially in the difficult airways. So coming to the end of this video, fiber optic bronchoscope is a very important device we have to know, and also the process of doing a fiber optic bronchoscopy has its own learning curve. So it's very important we understand what are the views, and also proper preparation of the patient helps a lot during this process. I hope this video was useful. It was a quite brief video. I try to include as much points as possible. See you in the next video with a brand new topic. Keep supporting. Thank you.